Okay, so I wrote this talk, I think it was probably a year ago, and it was really just sort of a composition of all the different tips and tricks and things that we've learnt as a group over the last sort of 5 years that I've heard of and personally experienced when doing the Accreta/per-Accreta patients that we have here. And we probably do, about one every 3 or 4 weeks on average, but it seems to go on sort of runs. So sometimes you'll have 3 or 4 really short period of time, and then you won't have any for months. Keep the current colour scheme, don't show it again. So there has definitely been a few. I did one with Karina 2 weeks ago, and then there was a per-Accreta yesterday, and there was another woman who was on the books, got done at Fiona Stanley a couple of weeks ago as well. So there's a few of them around at the moment. So this is not the definitive guide. It's really just my opinion, I guess, but it's really just I'm just trying to put together a helpful resource. So it gives you a sort of framework to think about when you're going to do one of these cases for the first time. And when I did the talk the first time, I did record it and I've put it on Dropbox. And usually what I do is, especially the senior registrars, if they're doing a theatre 4 with us, I say, go and have a listen to it, because it sort of goes over some of the things that I discuss. And I even got phoned by Neil Chambers about 3 months ago. He had one with Stuart Selfinger at St Johnny God Subi, and I just gave him the link to Dropbox, and he said it was the best thing ever. So I said, you don't need to worry, because they'll probably bleed less than an after-hour caesarean anyway, which was exactly right. Okay, so there's a million ways to skin a dead cat. That's the only picture I could find on Google of dead cats, which is pretty surprising. I thought you'd find more than that, but so I can't even remember these slides. So we don't have obviously interventional radiology here. So some centres do. So this talk is a little bit biased in that I'm not really going to talk about that very much, because I don't have much experience with it. I know, Matt, you used to use it in Exeter, didn't you? So it's not from the people I've talked to, it's not the be all and end all. It is definitely a good rescue device when things go wrong. And some centres place prophylactic balloons ready for, or even rebolus ready for inflation should things go pear-shaped. We don't have that here. We have had a few cases that we've sent to Fiona Stanley, because they do have the interventional theatre near the reception there. So I think they did one there about 1.5 years ago. So this is the most famous, infamous King Edward per-Accreta case. So she was a case from, Nolan's not here, I can't remember now. Nolan and Joel were involved I think it was about 7 or 8 years ago. Might even be longer. So she had an unrecognised per-Accreta which ruptured or started bleeding at home, and she had a perimortem caesar down the labour ward because she arrested. Basically, she arrived in the ambulance, and then she was in theatre all night. And the Red Cross, I talked to the haematologist from the Red Cross a couple of weeks later, and he said that he had to get up at 6 in the morning and go out to Jandakot to meet an aeroplane that was coming over from Sydney to replace all the blood that Wellington Street had run out of. I can't remember how much blood she got, but she got like 100 units of various blood products overnight. So it can be pretty catastrophic condition, or catastrophic hemorrhage. And there was a similar case that was reported and discussed at a haematology conference a couple of years ago from I think it was actually an elective per-Accreta that was done at the Royal Women's in Victoria. So you can see that when things go bad, they can go very, very bad in some of these patients. Having said that, most of the time they're pretty straightforward, especially the Accretas, and if they're an elective case. And usually when it's sort of well planned and well conducted sort of operation, they're less stressful than a after-hours caesarean where there might be uterine atony and hemorrhage from that sort of thing, or a tear. So I guess my approach, this is my personal philosophy, so I always assume based on that is that you never really know which ones are going to be the catastrophic ones and which ones are going to be the boring ones. So if anyone's booked for theatre and they've got known or suspected placenta accreta, increta, per-Accreta, any of those words get flashed around, then I just plan the anaesthetic around the fact that there could be catastrophic bleeding if we're unlucky. What do you do, Matt? Same thing? Yep. So just assume that it could go bad. So just to remind everyone, so this is the sort of graphic illustration. So Accreta is where it's invaded the myometrium. Is that right? And Accreta is the least severe form. Accreta has invaded the myometrium. So I think Accreta is just morbidly adherent. And perioperative is where it has gone through the serosa and is invading other organs, usually the bladder, but it can go anywhere really, anywhere nearby. So it can involve the bowel or go throughout the peritoneum. And obviously the placenta is a very vascular structure, so that's why it's such a problem. So we have a bit of a as a formal sort of process now. When they get identified, there's a team that's in charge of them now. I think it's the blue team. But there always has been a semi-formal process, and usually there's a few weeks to sort of try and get them ready for surgery. So all the people who are involved in the surgery are notified. They can have a chance to chat to the patients, but there's also a chance to optimise certain things. So certainly try and increase their red cell mass. So often they'll get an iron infusion or something like that to try and get their hemoglobin up and their ferritin up, because the more red cells circulating in their body before the start of the surgery, the better. What else? Yeah, so I think most of the time we only have a few weeks. So it's diagnosed and then there's a few weeks. If they have iron deficiency or iron deficiency anemia, to be honest, oral iron usually is not fast enough. So most of the time, I think the philosophy that most of us agree with is that they should get intravenous iron because it's going to work within a couple of weeks, whereas oral iron takes a couple of months in all reality. And then I'm just remembering, I'm getting flashbacks. I decided when I was putting together the slides for this talk, I wasn't going to put any words on them. So now I have to try and remember all the pictures. It's all right when you write a talk, but when you try and give it a year later, it's hard, isn't it? So what's this slide about? Anyone got any ideas? I've completely forgotten. Identify the people who are going to be involved and let them know. I think that's pretty much what I'm really. Yeah. Identify the patients. That's right. Yeah. Anyway, so the people they get to go and see usually, they see all the members of the blue team. That's the surgical team, and they usually see someone from the haematology side of things for optimisation of their red cell mass if they need it. Sometimes that's just a phone conversation, and then they should see us, and we just basically will tell them about how concerned we are and the plan that we're going to institute for the anaesthetic, and just explain all the different things that are not standard in a caesarean, because most of them have had a caesarean before. That's the reason they've got it. You get occasional people who get Accreta from surgery or previous surgery or conditions in the uterus that aren't a caesarean, so they might not have had a caesarean, but I'd say about 95% of them have had a previous Caesar and got a scar, and that's why they've got an Accreta. So they're sort of wondering why this caesarean or this anaesthetic is going to be different to their last one. I've heard that a few times.
How is it identified? Do people can you see it over the 20-week scan?
I think they know, so someone who's got a history of a previous Caesar, they know they've got a scar, and if they, at the anatomy scan, they look at where the placenta is. So if the placenta is anterior, then they'll probably keep a closer eye on them. But
scan again, and that's when
so I think that they follow them up. That's usually what happens. But yeah, they miss them sometimes. Most of the time they don't know, but yeah, it does happen. So you do miss Accretas sometimes. So it is. It does. You've got to be ready for unexpected Accretas. So when you're seeing the patient for the anaesthetic consult, so some of you guys might be asked to go and see them. They often aren't allowed to go home. They're sort of sat up on the ward, or sometimes they go across to Agnes Walsh House, but they especially if they've had a little bit of antepartum bleeding, they like them just to be in the building until their planned surgical date, and often they don't make it, so they start having a bit of bleeding and they just have to come to theatre after hours, which is less than ideal because it takes up a lot of theatre time and resources. But certainly for the patients who are having a perioperative, it's important, I think anyway, when I'm talking about the anaesthetic, to know what the plan is, because sometimes, I don't know what you guys did yesterday, there's a lot of time and effort devoted to putting in ureteric catheters and dissecting off structures and things like that. So the chance of being able to do a regional at the start of the case is much less feasible, I think, because they're going to spend 1 to 2 hours doing stuff before they even get the baby out, and it's a big midline incision. So it's good to know that, because then you can just say to the patient, I recommend we just do a GA from the start. That's what I've been sort of erring towards for percreters anyway, for the last couple of years. I know that it is possible to do a regional, and then once the baby, to try and allow the mother to see the baby being born, and then convert to a general anaesthetic later. But there's a lot of risks involved there. It's difficult to keep them comfortable if there's a long period of time before the baby comes out, because it's a midline incision which goes pretty high. But also it's less than ideal, I think, if there's a partner in the room and the patient is conscious when all of a sudden there's catastrophic bleeding, the blood pressure is 60, they're trying to vomit. You're trying to induce them without causing further hemodynamic compromise. So yeah, I've already preempted that discussion. But certainly for like a straightforward accreta, I think doing a regional is fine. So it all depends a little bit on the surgical plan and what they've seen on imaging and what they're planning on doing. Obviously vascular access, so I usually tell them all about the various lines and needles that we might put in them. Central lines, arc lines, big drips, big things in their neck if we can't get something big in their arm. Mention self-salvage, because certainly if they're under a regional too, they'll wonder who this person is sucking up all the blood and with the funny machine off to the side. And you've got to get consent from them. I've never had anyone not give consent, but it's important to explain the process and what's involved. And then occasionally they go to ICU. I think Tom Knight, when he was there, so he looked at about 30 of our cases, and we only had 1 out of 30 that actually ended up going to ICU. That was the elective cases. So it's normal that they just go to ASCU for HDU care, but occasionally they might have to get transferred. And then obviously you've got to talk about blood products. Now, I don't think we've had someone who refuses blood products with an Accreta yet, or a percreta, but I'm sure it'll happen one day. They're certainly described in the literature. Alright, so on the day, be prepared. Yep, I recognise this. I can figure out what this slide's about, which is good. So, so yeah, be a good Boy Scout or Girl Guide. Be prepared. So big drip. Here we go. A couple of big drips. Sorry. Stick in an outline. I've got. I suppose I should have some disclosures. I'm not sponsored by. I've never received any commercial funds from Vemflon or FlowTrack. Flow Switch. Sorry. I don't really like the FlowTrack, so I don't know why I said that. There we go. So there's a different arterial line catheter. So I'm not, favouring any one product over another. I'm trying to remember. Yeah. So I usually, especially when they're going to be awake, I actually put all of the big lines and things in with the ultrasound, because it's actually quite hard to keep someone on side when you're doing an Accreta, and you've got to maintain rapport, and so. I just think it's really important in that first. They come to theatre, they're really nervous, they're worried they're going to die from bleeding, and then you're going to do lots of procedures on them, and it's great to just put all the lines in without causing any discomfort, and it's easier to do that using the ultrasound. So I just stick the big drips and the outline in with the ultrasound, so that it's nice and comfortable, and they're all happy. So for large bore access, so usually we just use the 14 gauges, but if they don't have big enough peripheral veins, we have I think we do have swan sheath, but most of the time in the past I think we've just used the MAC line. We don't tend to need to use that very often. I haven't used one for a long time, but especially now with the ultrasound, you can usually get some big 14 gauges in their arms, whereas in the good old days, before we were good with peripheral access, we tended to have more trouble. I can't remember. I think I was just talking about being careful when you're dilating up large lines in the neck. Make sure you've got it in a vein. I'm scarred because when I did ICU many years ago, the intensivist I was working with my first day dilated up the carotid with a swan sheath. And then he pulled it out, and then the patient said, "I'm having trouble breathing." So it was very exciting. So yeah, so that's right. So one of the tips, make sure that the wire doesn't move when you're dilating it. Otherwise it can bend the tip. People probably know this, so I'm just this is just reiterating stuff. So a good rapid infuser. So there's the two most common ones used, I think, are the level 1 and the Belmont. We have the Belmont here. We do have a level 1, but I haven't seen it used for a long time. Has everyone here seen the Belmont? So it's pretty much, it's like a same principle as the cardiopulmonary bypass machine. It just has a what would you call it? It's a rotating pump, so it squeezes the line. So like a cardiopulmonary bypass machine, instead of having pressure bags, it has a not a centrifuge. I can't explain. A thing that compresses the line and spins around like on the a rollerball. That's what I was thinking. Yeah.
Sean Moulton is really good at taking me through this.
Yeah. And this is much more eloquent, I think. So it's really you can really precisely change the flow rates, and it's really good at warming the fluids. And
the units are mils per minute or something.
yeah, so you can start it off. So you've got a 14 gauge in. You can hook everything up. You can start it off low and make sure there's no swelling around the cannula, or there's no excessive resistance, and then just slowly turn the speed up. It's very elegant. Yep, and it can tell you the pressures, the back pressures it's getting, and
Yes.
yeah.
You literally just, I used it for the first time yesterday, but it's really easy to just press up or down.
Yeah. So it.
But there was it had a pressure sensor, so if it did test you, that
Yeah,
it
yeah.
would,
So it can sense the back pressure, and it will let you know if it doesn't think that the line's patent or the pressures are too high. Now you can't use, I think the level 1 as well, you shouldn't be using any of these two devices on anything smaller than a 14 gauge cannula. And in reality, you probably should even aim bigger if you're really going to try and pour a lot of blood products in. You should be looking at like a Rick line or a Mac line or a Swan sheath or something. So this is probably the most important thing on the day, and that is the team huddle, I reckon. Well, that's what the communication amongst the team. So knowing what the surgeons are doing, the surgeons knowing what we're doing, and everyone talking, so we know what's going on. And I think the team huddles, what kudos to Matt Epi, who's sort of pushed that in the last few years. It's a really good thing, and especially in a really tricky cases like this. So most of the time they're all having a Caesar hysterectomy. Sometimes, especially if it's like a straightforward Accreta, they might just try and put a Bacri in, or occasionally they're not sure if it is an Accreta. So the plan is not necessarily a Caesar hysterectomy from the start if it's like a suspected Accreta, and especially if the woman wants to maintain her fertility. So my observation here anyway is that the huge majority of them, it's just a planned Caesar hysterectomy from the start, but not always. Yep. So attempted placental detachment. So sometimes I actually get a little bit nervous about maybe the cases where they go, well, it might be an Accreta, because that could actually go a bit more pear-shaped than someone who they know it's definitely an Accreta and they just plan on doing everything carefully and taking the uterus out before it bleeds. So the other thing I've been caught out with before is if you're going to do a GA from the start, make sure the paediatricians know, and even better, try and get the paediatrician who's in theatre for the day to come to the team huddle. Because usually if the mum's asleep for an hour or so before the baby comes out, it usually comes out pretty flat. And if they've sent down one of their RMOs or something like that, then that's not very fair on the paediatric doctor who's there if they're not experienced enough to deal with a completely anaesthetised baby. It's good. So it's good to talk about the team huddle and cell salvage. I think it's quite good. I don't know what you do, Matt. I know I try and figure out at the team huddle. I say who's going to be holding the sucker, and the one we did with Karina 2 weeks ago, I just said don't set up the other sucker. I just decided to just use one suction. Well, maybe we can get Matt to do a talk about that. But there's a lot of centres around the world now, especially in the UK, that just use one sucker. So don't get obsessed about sucking up amniotic fluid. But I won't sort of digress. It makes it much easier for the surgeons to collect the blood if they don't have a suction which is going to where all the blood's going to get sucked into another sucker and get lost. So just, if you don't give them the choice, then they have to collect it, and then you don't miss out on it, if that makes sense.
Is the point that they try to avoid amyloid fluid, or that it just
No.
doesn't matter even?
Yeah. So I think so there's no evidence that having 2 suctions seems to be any safer. I think what it does do though, if the patient had like polyhydramnios or something, so 2 litres of amniotic fluid, if you sucked all that clear fluid up and filled up the cell salvage reservoir, that is a real pointless exercise, and it makes it really hard for our cell salvage person, our tech who's doing it, to then process blood and things, because you overfill the canister. But the truth is that usually that's not the case. Usually most of the stuff that comes out is pretty red, and if you just suck it all up, the evidence is that the washing and processing is as good whether you use 1 or 2 suctions. And even if you use 2 suctions, you're being naive, thinking that you're getting rid of all the amniotic fluid anyway. It's really, there's always going to be some in there. There's never been a case so far of amniotic fluid embolism triggered by cell salvage that anyone's reported in sort of 30 or 40 years of obstetric cell salvage now. So that's reassuring. It's not to say it won't happen, but and then aortic compression, especially in the really big cases, I think it's quite good to say who's going to do that. So I like to say, if you guys, if we lose control of the circulation at the top end here, I want one of you guys to press on the aorta for a while until we catch up. So who's going to do it, and does that person know how to do it? It's not that hard, especially when the abdomen's open. But it is nice to just sort of verbally say it, so then people know that they might be asked to do it and they've thought about it. Whereas, I know yesterday that things got out of control for a while and you did it a few times, and certainly a very useful technique. It's a bit like poor man's Reboa or interventional radiology, you can, but it's probably, it's definitely less technical. You don't have to know how to float a balloon. But it can be used even outside this sort of surgery. You don't have to have an open abdomen. You can just do it in other obstetric hemorrhage as well. So make sure you let the blood bank know. Check on all that, because sometimes you can get caught up in the morning doing all the lines and team huddles and things like that. The one we did a couple of weeks ago, we got a couple of units up and put it in the recovery fridge. So what you shouldn't do is get blood products up and just leave them in an esky in theatre. Put them in the fridge in recovery and sign them in properly, because then if you don't use them, they can go back down. If you leave them in an esky, invariably if it's been more than 30 minutes, then they have to discard it. And surprisingly, a lot of the time you don't need to use the blood products, so don't panic. It's only 30 seconds away in recovery. So that's probably a sensible thing to do, especially in the more high-risk cases, or if the patient, the one we had, she had a starting hemoglobin of 90, so we knew that it was a high chance we were going to need to give her some blood. But if you had a patient with a hemoglobin 150 and she only had a suspected Accreta, you know that even if she bleeds, you've got quite a bit of time. I think as soon as you've got the outline, and do a baseline rotum just so you can figure out what their hemostatic reserve is. So you can see in the top patient here, the fib-TMA5 is 14, so that's okay, but it's not amazing. So if that person there lost half their blood volume, you could easily see that their fib-TMA5 could get dropped below 10 pretty quickly. But the other person, this is similar to what we had last 2 weeks ago, the fib-TMA5 is 25. So if your trigger is going to be 10 millimeters of fib-TMA5 of 10 millimeters, you've got heaps of room to move there. So that and you can see the XTMA5 59 now. So that person could lose half their blood volume, and they're probably still actually not going to be coagulopathic. So that just gives you an idea in your head as to how well off they're starting. And it's not infrequent in women in the third trimester to start off with very high fib-TEMs like that. But occasionally you get caught out. So, I've seen someone did a baseline rotum and the fib-TMA5 was 11. So actually before they'd even started surgery, it was already on the edge. I just give tranexamic acid to everyone now. It's like I just treat it like a case, like a joint or something. They're going to bleed. Why wait till they bleed? So give them some tranexamic acid at the start of the surgery.
I was asked, is it alright to do it? Do you have to wait till baby's out?
I don't. I just skip it. Yeah. What do you do, Matt?
Yeah, there's actually quite a lot of studies now that have shown that giving it before delivery is effective. One of these studies has been real powered for neonatal outcomes. It's a very good, I think it's fine. But there's quite good evidence that it does reduce blood loss if you do especially when you know it's going to bleed or these kind of cases.
Yeah. So it's almost, no doubt that they're going to bleed. So might as well have it on board.
The studies I've seen being for seasons.
Yeah, so I don't think there's actually been studies on placenta accreta. It's just been like randomised trials of people booked for cesarean, yeah.
And a recent meta-analysis showed a reduction in blood loss.
Yep.
It's given in cardiac surgery anyway, and they're giving babies for cardiac anastomosis surgery, so it's not like completely wild if the baby.
Yep. Yeah, and I think most babies want to have a mother when they grow up, so it's, not that we're going to let them die, but you know what I mean. I think the risk benefit in someone.
We should almost make it, I think.
Yeah. Make it a to-do. Yeah, it should be on the check card. Give everyone tranexamic acid. Yeah. I think the evidence is mounting that it's a pretty safe thing to do, isn't it? The Atticus trial and all these high-risk cardiovascular patients, there was no increased incidence of thrombosis or serious events. So cell salvage. So this is actually the wrong machine. So we don't use this one anymore. We do have it somewhere in the back cupboard. We use the Medtronic device now. We sort of touched on that before, so maybe I'll skip over that. This is our theatre team. Don't use the other suction. So consider not using the other suction because it's much more feasible. So you collect all the packs, only give them one suction, and then pretty much the success rate of collecting a lot of red cells is pretty high.
Which I think the only caveat to that is if you're absolutely closing the cell so it won't keep up with the
That's
blood
right,
loss,
yeah.
you do need to get it out of the
Yep.
central field or something like that.
That's right. And so my personal take on, if people are absolutely hosing now, instead of cranking up the Belmont and sucking it up, as they should be compressing the aorta and stopping any blood flow to the lower half of the body for that period of time until you get control. If that makes sense. But yeah, you're right. Yeah. So that's probably the best way for them to dry the field and to see what they're doing. But if they're absolutely hosing, they can't see what to stitch or what to take out, then the self-salvage sucker isn't as good because the suction pressures are lower and the suction flow rates are lower. So
the nurses then set up their suction on standby or not?
it's very easy. They set it up
But not use it.
at the end of the case last time because they wanted to do some washing or something like that. And they could do it in about 30 seconds, yeah. So.
Yesterday, when they did the wash, apparently the nurse emptied the wash into the cell saver, where it all got suctioned up in the cell saver, and there was like a debate as to whether.
So as long as it's saline or crystalloid, saline, it has to be saline, so you'll be a bit careful because sometimes they try to wash things with water. Especially like the cancer surgeons, they like, the water causes hemolysis of kill cells, so they have a little bit of a habit of washing out the abdomen with water. You don't want to suck up chlorhex or iodine or chemicals or water. So there's various lists of things that you don't want to collect because it's all going to cause hemolysis or, it's toxic intravenously. You don't want intravenous chlorhex. And the processing of the reservoir collected blood is not going to get rid of chemical contaminants like that. So yeah, you do have to be very studious as well. So that's probably another good thing to mention. Actually, Team Huddle they're not allowed to tip or anything or use anything without running it past you as well. That's a good point. Oxytocin. So this is a good one to talk about. So it's a little bit unclear what's the best strategy. So, we're all used to, in caesareans, as soon as the baby's out, we give a bolus of oxytocin, start the infusion. But there is some people who believe that if the placenta is still attached, placenta accreta or perioperative is still attached and hasn't started bleeding or caused any problems, that giving oxytocin at that stage, when they're sort of carefully trying to do the hysterectomy, causing a vigorous contraction of the uterus, could actually cause the placenta to then detach and start bleeding. So there needs to be sometimes it's better not to give the oxytocin if everything's stable, because you could actually make things worse. But then if the placenta does completely come away and they're hosing, even when they're trying to do the hysterectomy, some sort of myometrial contraction around those vessels might help staunch the flow of blood. So it might actually then the plan change, reverse completely, and then you should give some oxytocics. So this is a good thing to discuss, and usually that's exactly what we discuss at the start. It's like, we won't give oxytocin if there's no bleeding. At the time of delivery, can we have like a very brief discussion as to whether we should or not? So not sure what happened yesterday, but that's, and so especially in the straightforward cases where it's very contained, and the surgeons are very careful when they're manipulating the uterus as they do the hysterectomy, and they basically just sort of devascularise it and then take it out, and there's no bleeding at all. You don't need to give oxytocin, but you should have it all ready to go in case things go pear-shaped. So I like the American Society of Anesthesiologists motto, vigilance. So you really have to be vigilant, and sometimes you have to be more vigilant than the surgeons are. This is coming back to me now. So some of the worst torrential bleeders have occurred. So what they use, the surgical technique often is, what they do is they'll deliver the baby, they make some sort of midline incision up near the fundus or somewhere away from the Accreta, and then they'll gently just sort of close it up and then start doing the hysterectomy. So of course once they've done that, they can't see if the placenta then detaches and starts bleeding, and what happens is it all pours out the vagina. So I know Ian had a case many years ago. It was like giving big boluses of metaraminol and going, "What's going on, guys?" And the surgeons were like, it's all good, it's all good. And then some RMO who was standing between the legs goes, "My gum boots are full of something." And they had a look, and there was like 2 or 3 litres of blood down the bottom, and it was just hosing out. So vigilance, So that's what I do as well. Actually, I go around and I actually just every couple of minutes, maybe every 4 or 5 minutes, have a look under. Whoever the scrub nurse is down that end, I say, "Can you just keep an eye on the drapes and that person's shoes and tell me if anything is coming out?" Sometimes it fills up in that collection pouch, so it doesn't actually even hit the ground. So, always so make sure you know where the surgeons are up to, and once they've closed the uterus, that's where you should be looking. So any signs of sort of hemodynamic instability, you should start suspecting that there's concealed blood loss. Oh yes, right. So what you do when the wheels come off? Aortic compression. Hopefully that's not what your monitor looked like yesterday. Probably a bit worse. I heard it got down to about 60. Not sure what the rhythm on that patient is. That was the only thing I could find on Google Images though. Usually they're still in sinus rhythm, not some sort of arrhythmia. So there's a really good YouTube video from this guy, Stefan Bergström. He's a Swedish obstetrician from Stockholm, but he's spent a lot of his life, in his latter years anyway, in Africa, and he is a huge proponent of using manual aortic compression. He's got this great YouTube video which I send the link to everyone to watch, and he shows everyone how to do it. And this is like an awake patient. It's actually really easy to do. So if you ever get someone comes up to theatre having a manual removal of placenta, or who's bleeding and is under an epidural or something like that, or even if under a GA, just have a feel of, go when the surgeons are busy stitching up or putting in a backry, have a feel of the uterus, make sure it's contracted, and then just right next to that, just carefully do what Stefan's doing here. Just find the aorta and just carefully press down and see how easy it is to do. It's very easy to do this manoeuvre, and it's not uncomfortable. In his YouTube video, he does this in an awake patient. It's not uncomfortable for them, and the aorta is actually not that far below the skin. So there's a really useful thing to know how to do, especially when you get caught out.
I see a really fat patient.
Yeah, so fat patients are a bit trickier, I suppose, aren't they? But yeah, I guess so. It's pretty hard because the vent cava is right next to the aorta. So I think, so you're probably going to decrease venous return from the legs, but you're going to stop bleeding from the torn vessels. So I think on balance, the overall hemodynamic effect in someone who's hypovolemic is probably going to be beneficial. It seems to be anyway. So this is just a slide to show that you can do this sort of thing with interventional radiology. So you can use iliac balloons, or you can use Reboa. You have to be lucky enough to have those skilled interventional proceduralists, which is usually a radiologist, but I'm told that some vascular surgeons can do this quite well as well. So certainly if you're lucky enough to be in an institution where you have good interventional skills and imaging, then you should consider doing that as well. So they have balloons in place and they can inflate them if they need to. So what about if you have to induce someone who suddenly becomes hypovolemic and they're under regional? Just have a plan in your head. There's no one way to do this. Everyone has their own. I'm sure everyone has thought long and hard about how they like to put people to sleep when they're in shock of some sort. I like to use a bit of ketamine and some sort of muscle relaxant. But just have, so it's useful, I think, I'm trying to remember this, if that is your plan and you're doing a regional, I think if you're going to do a regional, ask your tech to get the ketamine out of the cupboard and stick it on the trolley, because if that's your plan to induce them, the techs here, you have to find the tech with a key and then they have to go and sign it out and blah, blah, blah. So you don't want to be waiting 5 minutes for them to find the ketamine. I think that's the reason I put that in. Because what you'll find is there'll be some sort of catastrophic cardiovascular collapse, and you'll probably just have to go ahead with some propofol and something else. So cryo and fibrinogen concentrate. So we have both in this hospital. If things are really bad, the fibrinogen concentrate is a lot faster. It's still kept down in blood banks, which is a little bit of a debate, but when it comes up, you can mix it up and give it an adult dose within about 15 minutes. I've done it in about 10 minutes with Jeremy about 9 months ago in the middle of the night. So that if things are really bad, you want to get lots of fibrinogen in quickly. So you're probably better off using the fibrinogen concentrate. And I think we have our guideline is if the fib TMA5 is 6 or less, then you should move to that instead of cryo, which takes longer to thaw, and you've got to check it and someone's got to bring it up. And probably, in reality, you're looking at 30 to 45 minutes if you're using cryo. So communication is the main thing. Analgesia. So this is good to discuss. So basically, they have a relatively big midline incision. There's lots of different ways to do this. I don't think there's any right or wrong way. So the different options are you could place a thoracic epidural before they go to sleep or before the surgery starts if they're awake. That's pretty good for this sort of thing. You could do a spinal with some intrathecal morphine. Or you can do rectus sheath catheters, which are a bit more tricky in the obstetric patient because the rectus muscle is displaced by the pregnancy, and so it's a bit harder to find the anatomy. But it is still feasible. So I suppose if you're confident that you can get that to work, that's another option. And also you can even run intravenous lignocaine down an ASCU if you need to, as a sort of rescue if they haven't got a regional. Those are sort of the main approaches I think we've used. So those are the rectus sheath catheters. That's not a pregnant woman, but that's the only image I could find on Google. That's actually a young Dr. Salter. That's what he's on Google if you Google images for epidurals. I can't remember why I put that picture in, but it's nice to have him in there, isn't it? A little cameo. I'm sure there was something I was going to say. I've forgotten what it was. Anyway. Intravenous lignocaine. Here we go. ASCU versus ICU. Yeah, most of them go to ASCU. So really, why would you send someone to ICU if you thought they needed high dose vasopressors or respiratory support, I suppose. Otherwise, they should be fine to stay here. Thromboprophylaxis. So even though they've bled a lot, they're actually the more you bleed, the more risk you are of thrombosis. Surprisingly, because your body has a response to the stress of surgery, such that at about 24 hours you are more prone to thrombosis. So most people are reluctant to give heparin in these patients. So and they're all pretty immobile down in ASCU. So I think you should have flotrons on them so that they sort of maximise the non-pharmacological stuff. And then as soon as the the team are happy they're not going to bleed, probably should stick them on heparin. And if they do have some bleeding, you can treat or can augment the postpartum, the recovery from the postpartum anemia by giving them some intravenous iron. Rough rule of thumb is that 1,000 mils of blood has about 500 or 600 milligrams of iron. So 2 litres of blood, they probably need about 1,000 milligrams of iron. That's, we have very complicated sort of tables in the guideline, but they're sort of designed more for people with chronic iron deficiency anemia. All right, so assume the worst. Make sure you've got the right team. I reckon the team huddles are a good thing to try and discuss all these things. Obviously, you need good lines, and don't forget aortic compression if things go bad.